pleasure for us to welcome all of you for this international webinar series. We have an excellent speaker with us, going to be speaking about a very interesting topic. And I'm sure you're going to enjoy this topic, learn lots out of the speaker here. It's my proud privilege today to welcome Professor Dr. Atul Mohan Kochhar. He obtained his MBBS and MD Dermatology from the prestigious Delhi University. He was awarded the University Gold Medal for Excellence in the field of dermatology. He's also a diplomat of National Board, a member of the National Academy of Medical Sciences, and a fellow of the American Academy of Dermatology. He worked since 2003 as a professor and consultant in the Department of Dermatology and STD Lok Nayak Hospital and Maulana Azad Medical College, New Delhi. He is the recipient of several awards, including the prestigious Sardari Lal Memorial Award for the year 2015. He is the current President, Society of Pediatric Dermatology and Founder Secretary, Scientific Cosmetological Society. He has more than 70 publications, 4 books, and many chapters to his credit. A very active practicing clinician with a passion for quality in healthcare, he has since 2019 taken charge as the Chief Executive Officer of the National Accreditation Board for Hospitals and Healthcare Providers of India, the NABH. Promotion of patient safety, quality, and taking best healthcare practices to the last of the line are his mission in life. Thank you very much, Dr. Atul, for accepting our invitation. Over to you, sir, for moderating the session.
Good afternoon, friends, and thank you, Dr. Lalu, for that very kind introduction. So, friends, my name is Dr. Atul Mohan Kochhar, and I am from NABH, and I'm extremely grateful to CAHO for giving me this opportunity today to moderate another fantastic webinar. The topic today is patient safety, checklist, culture, and the patient's perspective. So patient safety, as we are all aware, is the fulcrum around which the entire framework of standards, accreditation, etc. revolves. And it is the linchpin which binds all of us together, whether it's ISQua, the umbrella, the mother body, whether it's CAHO, which is doing such fantastic work. And thank you so much for sharing that very foot-tapping anthem, which shows the unity, the strength, and everything which binds us together. But today, without much ado, the core area, the checklist, which is all about SOPs, then what about the culture of patient safety? How to go about it? How to interpret that? And what is the patient's perspective? What role does it play in the entire ecosystem? To deliberate on that, fantastically, we have a very special guest today. It's my proud privilege to welcome Dr. Oliver Groene. He's the current Vice Chairman of the board at Optimedis, Germany, responsible for the areas analytics, research, and innovation. He's also co-founder and director population health of Optimedis CO BIC UK. From 2011 to 2015, he was senior lecturer in health services research at the London School of Hygiene and Tropical Medicine. There he developed novel methods for assessing and improving the quality of care. As senior methodologist at the Royal College of Surgeons of England, he led the implementation of large-scale national clinical audits on the quality and safety of care, in particular in the field of esophagogastric carcinomas. Prior to that, he led the Quality of Health Systems program at the WHO Regional Office for Europe and served as Director of Research and Education at the Evidis Donabedian Institute, Autonomous University of Barcelona. He publishes very regularly in peer-reviewed, high-ranking journals. He was the deputy editor for the International Journal for Quality in Healthcare for a good 5 years, from 2015 to 2020. He obtained his first degree in medical sociology at the University of Bielefeld, followed by a Master of Science degree in public health at London School of Hygiene and Tropical Medicine, and then a PhD in public health at University of Febra, Barcelona. So warm welcome to you, Dr. Oliver, and we are all ears, very eager to listen to you, and I'm sure there are going to be many questions for you, sir. All welcome once again, and he's a very music-oriented person. He plays the Spanish guitar, and the excellent, fantastic architectural wonder behind him is the Philharmonic Opera of the Hamburg. So over to you, Dr. Oliver. We are all ears.
Thank you very much for the kind introduction. Delighted to be here with you today, even though from the distance online. But I'm really looking forward to this webinar and the discussion. I'm sure you're going to have a lot of questions, because I understand there's a very high number of professionals attending this webinar and experts to get engaged in the discussion. So the title is Patient Safety, Checklists, Culture, and the Patient Perspective. And thank you very much for the introduction on that topic already. You can already see from the title that I'm trying to cover quite a bit of ground. And the question is, well, what does a checklist have to do with a patient perspective? And what does a patient perspective have to do with culture? And that's already sort of one of the key issues that I'm encountering in healthcare, not as a doctor or as a nurse, as many of you, but as a researcher coming from a social science and public health background. I'm looking at systems of care organizations and asking questions, how we can study these systems, and how can we learn. And I've spent a good part of my last 10-15 years on various aspects of health services research and patient safety research and clinical effectiveness research. And I've put together some pieces of my research to build a story, a narrative that I believe is worthwhile sharing, and certainly was for me a journey of discovery over the last 10 years. So let's just get started. I don't have any conflict of interest to declare, but I have to declare that I'm not familiar at all with the Indian healthcare system. So you can see here, for example, the disability adjusted life years, so the numbers of years of life lost to disability or death in Western Europe. And the blue boxes are conditions of non-communicable diseases, cardiovascular disease, cancers. And you can see non-communicable disease account for a very large part of the overall disease burden in Western Europe. You can see in the green area that we have a smaller component of disability adjusted life years linked to accidents, and the red part are the disability adjusted life years linked to communicable disease and neonatal disease or conditions. So this is a typical picture of any Western European country, with some variations, of course, and similar to what I've also encountered working in the United Kingdom. You will be much more familiar with this picture that I've pulled from the Global Burden of Disease study. And these are the disability adjusted life years in India amongst all sexes and all ages. And of course, what I have learned from this, which I knew already, but I double checked it, is that there is a double burden of disease, or even a triple burden, with non-communicable disease becoming more prevalent. At the same time, still a very high proportion of communicable disease and also accidents and injuries. And that, of course, has major implications for the type of work done in healthcare and for the type of patient safety strategies embedded or implemented in healthcare. And I'm aware that in India, you can find some of the finest healthcare facilities in the world, but I'm also aware that some of the healthcare facilities are very variable in quality, staffing, and equipment. So I'm just putting this up as a disclaimer that what I'm presenting represents my experience working in European countries. And I anticipate that some of the findings may not fully be applicable to the setting where you might be working. So that's just to start. Briefly, as an introduction, what is patient safety? We've all probably worked many years in this field, but it's always worthwhile to start with a definition. And I've taken this up from the recent Global Patient Safety Action Plan from the World Health Organization. And patient safety here is defined as a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies, and environments in healthcare that consistently and sustainably lower risk, reduce the occurrence of avoidable harm, make errors less likely, and reduce the impact of harm when it does occur. So I think the definition is very clear that patient safety covers a wide area of research and implementation. It's not just a selected intervention. It's not just the work of one type of profession. It actually covers a whole system of care, the system in which care is provided. And also it is linked to various outcomes, some which have direct implications, some which may not have an implication, but could have had an implication, such as near misses and so forth. So that is a definition, just to make sure we all start this webinar with a common understanding of patient safety. In terms of the understanding of how errors occur, or better said, how actually results are being produced in healthcare, it's worthwhile reflecting back on the simple triads of structures, processes, and outcomes that Avedis Donabedian introduced nearly 70 years ago. And I had the privilege to work at the Avedis Donabedian Institute in Barcelona and had access to some of his manuscripts that were still available there. So studied and admired this work. And the graph that you can see here is from colleagues in the UK that built on the structure, process, outcome theme and try to break it down into various components that reflect the breadth of patient safety and that focus on some activities being very professionally driven, which are the root of the daily work of doctors and nurses and allied professions, and some processes which are not directly to work, the daily work of a doctor or nurse, but actually are more related to the management process and the design process. So in this graph, you can see that the structure and processes run from top to bottom. You can also see that horizontally, in terms of improving patient safety, there's a complexity in the sense that any intervention to improve patient safety can first be distinguished as a generic intervention, say one that makes a generic care process safer, and a specific intervention, which is an intervention at the bedside for a specific patient. It also introduces the concept of fidelity, which is a very important concept, which basically refers to the fact that any intervention is rarely fully implemented as intended, because there are many other factors that have an influence on the implementation of this intervention, being generic or specific. So we need to take that into consideration. We then have latent errors that occur in designing a process or implementing a process, and we have active errors that occur at the bedside, errors based on acts of doctors and nurses or others, but active errors that lead to patient outcomes. And you also have intervening variables. Moral is mentioned here. Moral for me is an aspect of culture and climate, but you also have other intervening variables, which is basically the infrastructure of the organization, the setting, the number of patients, and so forth. So this is an important understanding of the epistemology of patient safety. A similar sounding word, epidemiology of patient safety. Again, many of us have seen these data. I just wanted to show that again to make sure that we have the same understanding and data. Patient safety events have been researched for many years, starting in the 80s with some of the early studies at Harvard Medical Practice. And all those studies here, and there are more of this kind, are based on retrospective case record reviews. So a team of experts taking a sample of patient records and seeing whether for patients where harm was established, what kind of factors led to that harm, and to understand the causal factors for this. These random record reviews also help to estimate the number or the proportion of adverse events that occur in healthcare. And you can see that depending on the study and the methodology of the study and the setting of the study, these adverse event rates vary. It is now, however, well established amongst patient safety researchers that on average about 10% of patients do suffer some sort of adverse event, not all of them having an implication such as a surgery or an amputation of the wrong leg. That's the worst, or the kind of worst patient safety accident that might happen. There are many other patient safety events that may not have a direct implication for a patient, but are nevertheless patient safety adverse events. And there's an excellent textbook on surgical patient care that I can recommend, almost 1,000 pages, I think, that summarizes a lot of the patient safety research, particularly in the field of surgery. So another figure, and this is the guiding figure for a lot of the research that I will present. This research started about 10 years ago, when I had the major opportunity to work with the leading group of quality and patient researchers in Europe on a large-scale European Union funded study on quality management, quality and patient safety. And we have taken this diagram that I showed earlier about the epistemology with management processes, clinical processes, and outcomes. And we have tried to operationalize this framework into a specific model for which we then collect the data in a large number of European hospitals. And if I can just take you through the model from top to bottom, because it's important to understand the research. We started with the fact that hospitals are exposed to various forms of external pressure. External pressure meaning any type of pressure influence that obliges or forces or influences a hospital to do something. One example of external pressure is a legislation in a certain field. Another example is an accreditation procedure. That's a perfect example of external pressure exerted on the hospital to adopt SOPs and various other processes in line with standards. Clinical guidelines are also external pressure. You then have hospital governance, which is a board level discussion amongst the hospital staff, where a lot of the guiding principles or strategies are being set. Underneath the governance level, there is a management level and the quality improvement system. And this is where at the hospital level, at least conceptually, a lot of the decisions are taken about Is there a process to collect data systematically from patient records, or even the decision, how do we invest in our patient records to make sure that we can work with the data in a way that helps us learn from the data? Then lateral to this is the concept of organizational culture, one of the topics for today, and professional involvement. To what extent is the quality improvement system actually taken on board discussions or reflects the attitudes of staff, and to what extent are professionals involved in the deployment of this quality improvement system? And these are systems that are working hospital-wide. However, hospitals are very complex, and you often have many different departments in hospitals and care pathways. So we have taken the decision to focus on 4 different disease groups. Well, delivery is not a disease; it's a happy part of healthcare. But say 3 disease groups and delivery, it's simply for the fact that we needed to be specific about a medical, clinical context. We couldn't study everything, and we need to look at high volume areas of work. And these 4 areas are of high volume in European hospitals. And then at the patient level, within the departments, we collected data on patient safety, on the outcomes of care, also on patient perceptions. So that's the overall conceptual model of the study that we used. So let's start with a very concrete and tangible piece of work, which is a patient safety practice. Now, the patient safety practices came out of a lot of research, some of which really well driven by the Agency for Healthcare Research and Quality in the US. And there was a seminal paper by Schickel and others about strongly encouraged patient safety practices. And these were practices for which there was a very high, a very strong evidence base, but also for which the implementation potential was seen as very high. And you can see here some of those patient safety practices. Apologies, I'm noticing there's a typographic error. So examples of that would be pre-operative checklists, particularly in the field of surgery, anesthesia, or the implementation of bundles to reduce central line associated bloodstream infections. I'm going down the list. Hand hygiene as a broad theme is a broad area of patient safety where a lot of evidence has accumulated, or multi-component interventions to reduce pressure ulcers. So these are just some examples on strongly encouraged patient safety practices. And they're quite important because they help to prioritize various areas of implementation rather than trying to make healthcare safe, which is a mission or a vision, but it's very difficult to do that unless you break this down in very specific clinical areas. So these are some of those specific clinical areas. We then thought it would be good to study the implementation of those evidence-based practices, because many governments in Europe have proposed these, many medical associations have proposed them, and they reflect a broad consensus also on especially in Western European countries, on what should be done in terms of ensuring patient safety in healthcare. So this is the first study that I'm showing based on the conceptual model that I outlined earlier. And that was done together with Professor Rosa Sugnol and colleagues. And the title is Evidence-Based Organization and Patient Safety Strategies in European Hospitals. Now I have to explain what we mean by evidence-based organization. I've shown you an example of patient safety strategies or practices, so very specific areas of patient safety, such as hand hygiene. But evidence-based organization of care pathways are a number of indicators that we derive from clinical guidelines. So for any kind of, say, stroke, acute myocardial infarction, we went through the clinical practice guidelines at European level and identified the key components that are related to the way care is organized And based on that, we built indicators and then assessed to what extent these indicators are being implemented in the European hospitals. And we wanted to know whether there were any difference between countries, but also within countries and even within hospitals. This was a mixed method, multi-level cross-section design with 7 countries participating in the European Union. And the study was called Deepening Our Understanding of Quality Improvement in Europe. And we had 74 acute care hospitals for this part of the study, with 292 departments managing AMI, hip fracture, stroke, and obstetric deliveries. Now, I'm sorry, this slide is very busy, a lot of data, but I'm going to talk through it. So this is showing the compliance with patient safety practices. And you can see on the left side the number of, or the type of patient safety practices. The first, very simple, do patients have a wristband? There's actually European standard on that. So in 100% of all cases, this should be in place. Every patient admitted to a hospital should have a patient wristband. We could see, though, that within these 4 study areas, the compliance was highly variable. So for the departments that took care of the AMI patients, we didn't call them, by the way, cardiology or internal medicine or other departments, because within the country, we didn't know in those hospitals which department actually would take care of those patients, whether there was cardiology or whether they were in shared with other departments. So we are breaking this down here by the disease areas. And you can see that from the hospitals that participated in the study and actually underwent an audit similar to an accreditation survey, only 43% of the departments were in compliance with this patient safety practice. On the other hand, an example, needle disposal boxes were highly available. 90% of the cases they were available. And you can go down the list and see that the implementation or the compliance varies for each of those high evidence-based patient safety practices. You can also see that it varies between the departments, and you can also see it varies between the countries. So it's a lot of variation. Variation in many contexts of life is good. It's what life is based on variation. But in the context of standards, quality standards and patient safety standards, which should be in place, variation to that extent is not something that we like to see. You can see a similar picture for the indicators that we had proposed for our audit. Here, I'm just showing you one example for the AMI audit, and you can see full compliance was achieved in none of the cases. There was reasonably high compliance for the standard immediate access is available 24/7 to a specialist physician to determine whether coronary revascularization is appropriate. But again, for other standards, that is highly variable. And again, between the countries, you could see a lot of differences. So it doesn't mean that one country apparently is better than another. Such a statement can rarely be made, but you can see within the European Union countries, which are a much smaller area of India, and each of those countries being probably even smaller, there is still a very large variation between the hospital services in one country. And that is, again, nothing that we like to see in such a study. So one of the questions is, why is there such high variability? And we looked at in our study whether this is related to the type of hospital. Is it a university hospital? Is it a community hospital? Is it related to the type of ownership? Is it public-private? Is it a context of the catchment area? We looked at a lot of those factors. But we didn't find a concluding answer there. So we thought it might be something more in relation to the priority that is given to the implementation of patient safety. And thus we came to the concept of patient safety culture. So this is from another study based on the same data and project, where we looked at quality management and perceptions of teamwork and safety climate in European hospitals. Now, just to define safety culture, it's often defined as the way we do things around here when no one is looking. So that's different to the culture when you have an expected survey of some sort, because then things are being done differently. But when no one is looking, when there's no pressure, when there's no accreditation survey, this is the way of things are done, and that reflects the safety culture. Often culture and climate, safety climate, are used interchangeably in the literature. And in the literature, usually cultures are deeper rooted aspects of climate, the climate being sort of the tip of the iceberg, the part that you can observe. The culture lies underneath the water surface. It's difficult to observe. And the patient safety culture is professionals' shared assumptions, values, attitudes, and behaviors. Some of that might be observable. Many of that will be difficult to observe. Climate, however, represents more shared perceptions on the way patient safety is conceived, structured, and implemented. And that is robustly measurable by surveys. There are many different surveys out there on patient safety climate. And the literature has focused a lot on climate as a multidimensional construct. So it has different components contributing to climate, but two particular domains that have emerged as particularly relevant in the context of patient safety. One is being teamwork, the other one is safety climate. And teamwork is, again, perceptions of healthcare professionals concerning working collaboratively to provide safe care. And safety climate is a professional's dedication to patient safety. So these are observable parts of climate on the top, on the tip of the iceberg, so to say. So in our study, we wanted to see whether safety climate is actually related to other components of quality management systems. So, for example, are accredited hospitals different? Do they have a different safety climate from all those processes and SOPs that are being implemented? Is that an association that we're seeing? And we also wanted to see whether there are differences in perceptions of teamwork, climate, and safety climate amongst clinical leaders and frontline clinicians. Because again, there might be a gap with what leaders believe reflects the teamwork climate and safety climate and what frontline clinicians actually experience. The setting was the same, 7 European countries. We had 3,622 clinical leaders and 4,903 frontline clinicians participating. And for those interested in the details, we used the survey developed by Sexton, the Teamwork and Safety Climate Survey, and we used the abbreviated scales for only teamwork and safety climate subscales. And these are survey questionnaires with Likert scales from strongly disagree on a given statement to strongly agree. And there's a cutoff point about an individual scale scoring higher than 75 being an indication of positive climate. And again, think about the conceptual model that I said, that I explained. We have a hospital-wide quality management system, and we wanted to see whether this has implications on patient safety culture of clinical leaders and of frontline clinicians. And of course, we looked in our study also on other factors such as hospital characteristics, beds, or respondent characteristics, profession, gender, age. And the findings of this study were quite interesting. So the teamwork climate was reported as positive by 67% of clinical leaders and 43% of frontline clinicians. So technically, based on the literature, the average result doesn't suggest there is a good teamwork climate and a good safety climate in all those hospitals participating. So there's a substantial room for improvement. The same goes for the safety climate, substantial room for improvement. The interesting point, though, is when you look at the data in more detail, let's just look at the yellow marked data points. So we have here the subscale on teamwork climate, working collaboratively together. And we have a positive assessment of 66%, 67% by clinical leaders, and 43% by frontline clinicians. So the frontline clinicians experience the implementation of all patient safety aspects on the teamwork much differently, much lower than the clinical leaders. And if you go even deeper in the data, if you look at the teamwork climate amongst the clinical leaders, you can see the answers from physicians and from nurses. And the nurses have a much lower assessment of the teamwork climate. The same goes for the frontline clinicians. And here, the differences are even starker. Physicians saying 51.7 positive teamwork climate, and nurses only rated as 36.5% positive. So again, not just gaps between leaders and frontline clinicians, also within the professions. And of course, patient safety requires an interdisciplinary focus. It requires working together. We know that a lot of patient safety issues are related to communication issues, and communication involves all members of the team. And without a good teamwork climate, it will be difficult to achieve a high patient safety. If we go on, if we go towards the patient perspective, so the question is, of course, there are a lot of patient safety issues that may be difficult to judge by a patient. The patient safety practices, for example, some of them are very difficult to judge. Of course, a patient can judge whether an ID bracelet is given, but where the potassium chloride is stored, that's something that a patient cannot judge. However, there are aspects of patient safety that patients are in the best position to judge. And again, we know the impact of communication on patient safety and patient safety events. And we know particularly from the type of care that is provided in Western European countries for people suffering with chronic conditions and requiring multiple medications and care of multiple care providers, we know that they can make a major contribution to assessing the patient safety. We've just published 2 papers on the development of a new measure of assessing patient experience with patient safety in primary care. Now, there are, again, a lot of measures available on patients' experience with patient safety, but most of them focus on the hospital system, and most of them are very lengthy, very long, and difficult to implement in a routine setting. So we wanted to develop something that is much more concise, much shorter. We focus on 5 different domains because these are the domains suggested in the literature where patients can make an assessment, which is access to appointments, staff friendliness, consultations, interactions, medication errors, and care coordination. And to just give you an example on what these questions described or elicited is, if a new medication is prescribed to you, does your doctor explain in an understandable way how to take the medication in terms of dosage, frequency, time, before or after meals? And that again is scored on a Likert scale. Now that is a key issue, a key patient safety issue in European countries for the non-communicable disease that we are seeing in our care institutions because many conditions are of a chronic nature and require various medications that need to be taken in the way as prescribed. Otherwise, they are not effective. And we know, and our study also demonstrated that a large proportion of patients say, well, actually, rarely do I understand, or rarely does my doctor explain in an understandable way how to take the medication. The consequence being that the medications are taken incorrectly, or they're not taken at all, or in the best case, perhaps there's just a level of confusion requiring further information so that the medication can be taken. But from our perspective, a huge issue, a huge patient safety issue, because we know that a lot of adverse events from medication are related to the fact that the patients didn't understand how to take them. And that's not always because they didn't have the cognitive capacity to understand. It's actually the other way around. It's the professionals not explaining in a manner or not using communication techniques that really help communicate effectively. The same applies to the continuity of care. In German or in Western European countries, the care delivery is partly fragmented, and examination, lab results, information on allergies is being elicited again and again. It's never available. Many studies suggest that. And we ask the patients, does it happen that results of examinations carried out are not available, although they are necessary for clarifying your complaints or planning your treatment? And again, the answers that we got is very frequently are those results not available. And that in the best case may lead to only delays or excessive costs because of duplications or waiting times, but it can also have consequences on the health of the patient. This is a very well-established field, and there are dozens of surveys out there to assess patient experience. There are various surveys out there specifically also talking about patient experience with patient safety, and some countries are collecting this data routinely. That's reasonably well established. I believe, though, that there's still a huge implementation deficit. So this information is collected because in some countries there's a policy that it has to be collected. But actually, and we did that, if you ask hospital managers, quality managers, and professionals in the hospitals, for which we know there's a national system of collecting this data and providing it back to the hospital. And if we ask them, have you discussed this data in your team? Have you identified some patient safety activities or strategies in relation to this data? The result is often, I have never seen this data. We've never discussed it in the team, and I don't know what it could tell me. So there's a huge implementation deficit to working with data that can be directly collected from and with patients. Now, another point of the role of the patient goes far beyond being a subject which we might ask some questions. The whole literature about patient experience and the whole policies are well intended, they're important, a lot can be learned from this data. But there are many developments in Western countries now that go far beyond that and try to involve patients in rather different roles that go beyond being asked, did your doctor explain the medication? And this is often labeled as patient and public involvement. That's a broad field of research and literature, and there are different terms that are being used: user involvement, patient and public involvement, lay involvement, or patient representation. And we're using the term patient and public involvement to denote the involvement of patients or their representatives in activities related to planning, designing, or assessing quality management in hospital. So much more than actually asking them how was the communication. And we have built a a survey tool based on 5 domains of patient and public involvement, whether patients are involved in criteria development, process design, quality committees, improvement projects, and discussing of results. And here you can see some of the data, and the headline is very clear. We weren't surprised by that either. The level of patient involvement in formal quality and patient safety roles is very low in European hospitals. Basically, patients are never being involved in designing quality criteria, almost 60%. Now, this could be a great discussion with all of you, I'm sure. Why should they be involved? We are the experts, we are the clinicians, we know the kind of care we want to provide to the quality. But in the end, the patient is the final customer, client, the person that benefits from the care, and the person that needs to collaborate with the care professional, particularly when it comes to non-communicable disease. So there are many arguments to actually involve patients in criteria design. Design and organization of care processes, again, the answer was similar, almost never. However, if you there are some beautiful maps of care processes being drawn by colleagues from Harvard and from UCL, and they show the care map that a patient, particularly in the field of cancer, which I've studied, has to go through. Often 17 different care providers, 60 different points of contact. The information is never there. The patient is going back and forth, wasting a lot of time. And there are many opportunities to actually talk to patients, say, okay, this is a care process from our knowledge center, from clinical science, but how can we make it adjustable to the life of patients so that they can actually follow the care pathway? That's an important discussion. We asked 3 more questions: whether patients are involved in quality committees, again, low; quality improvement projects, low; and whether they are involved in discussing quality improvement project results, and again, very low. So the level of patient involvement in formal quality and patient safety roles is very low in European hospitals, and I wouldn't be too surprised to hear that it's low elsewhere. However, there are really interesting developments. I want to just mention one in the UK, in the United Kingdom, where a series of hospitals introduced, in addition to their chief medical director or chief director of nursing, they introduced the role of a chief patient director. And one of those patient directors actually being a patient representative, but it doesn't necessarily have to be, but a role at the highest level of the organization that bundles, integrates all those issues about patient involvement, patient adherence, patient waiting times, patient care design, to make the care more patient-centered. A very important discussion. So, how do we pull all of this together? After this study, we found many answers, but even more questions. And I've referred to that a couple of times in my talk already, that wherever we collected data, we found huge variation between countries, within hospitals, between professions in the same ward, in the same hospitals, and so forth. Variation everywhere. And that led me to think, how can it be that in an organization driven by expert medical and nursing knowledge, with the dedication that all those professionals are showing, how can it be that care is so variable? And there's an interesting literature that I could tap into from my first studies from sociology about high-performing organizations. And high-performing organizations are those that attain excellence across multiple measures of performance, multiple organizations all of the time, such as a nuclear plant. A nuclear plant cannot be run like a hospital. The SOPs need to have a very high level of compliance. Otherwise, we would be in real trouble. And there's a literature on high-performance hospitals. attaining excellence across multiple measures of performance in multiple departments and over time. And since all our research so far was very quantitative, I was very driven on using qualitative research to tap into the broader messages of the broader understanding factors contributing to performance. So we conducted with colleagues a systematic review of studies that used quantitative tools to assess high-performing hospitals based on performance data, and that then used qualitative work to understand really the factors contributing to high performance. We reviewed 11,428 studies and identified in total 19 for our review. And we identified 7 themes that represented key factors integral to high-performing hospital organizations. And these pictures, or these factors, are identified in this graph, which we intentionally drew a little bit, let's say, handmade, because it reflects the complexity of healthcare. And the 7 factors that emerged from the systematic review of really in-depth qualitative study on hospitals that have been proven to be of high performance, those 7 factors were positive organization culture, senior management support, performance monitoring, building and maintaining a professional workforce, effective leaders across the organization, expertise-driven practice, and interdisciplinary teamwork. And you can see there are a lot of different pathways within the organization, and all of those factors, all of those themes being interdependent. Recruitment of leaders of proficient workforce is a requirement to then have leaders that are driving the organization forward. They need data for effective performance monitoring and so forth. So it's all interrelated. And that we published this paper a few years ago together with colleagues. This is a paper that describes really in a nutshell how high performance organizations are looking like. So to wrap up, I've shown this graph, this figure at the beginning, the epistemology of patient safety. And I think that's one of the key points that I wanted to communicate. And from an organizational science perspective, hospital organizations are very complex. We have latent errors, active errors that lead to different pathways to patient outcomes. We have a high level of variation within hospitals and within professions. And if we really want to improve patient safety, it's good to start with something practical and concrete and tangible in one ward. But unless it's embedded in the overall quality management system, and unless that quality management system is supported by all staff and their culture towards improvement, then this is not going to work. So that's one of my key findings from the last 10 years of work. And again, coincidentally, also a list of 7. These are the guiding principles proposed by the Global Patient Safety Action Plan from the World Health Organization that underpin values to shape the development and implementation of a patient safety action plan, which is engaging patients and families as partners in safe care, achieving results through collaborative work in analyzing and sharing data to generate learning, translating evidence into actionable and measurable improvement, base policies and action on the nature of the care setting. Care settings differ. Use both scientific expertise and patient experience to improve patient safety, and I've referred to that. And importantly, instill a safety culture in the design and delivery of healthcare. I thank you very much for your attention, and I'm happy for the discussion now.
Thank you so much, Dr. Oliver. I think this has been a very candid, fantastic presentation. And actually, you have touched upon all the important integrals which govern the patient's safety scenario. And in fact, it's so reassuring to know that India is no different from Europe. Actually, Europe is what we aspire to be. But your deepening of our understanding of quality improvement in Europe, the DUQUE study, I think that's a path-breaking study. You've covered 74 hospitals, 292 departments, 3,622 leaders, and 4,003 frontline clinicians. I mean, still way to go, actually. So India, just, I mean, as you very rightly hinted, is 41% smaller than Europe, but about 3 times the population we have, at 1.5 nearly. I think we need a deepening of our understanding of QI in India study, and your 7-point formula will be the guiding principle for all of us. I truly appreciate. I think that's a wonderful path-breaking work, and Indian clinicians are no different, actually. But the eye-opener is your 18% of compliance, or rather, sorry, 2.8% of. I mean, so none of our clinicians are going to agree that they do not take any trouble to explain anything to their patients, actually. So, I mean, they'll be up in arms, and we might have whoever presents will be trolled, in India. So, so we actually, Lalu madam, we need such a large study across hospitals to show us the mirror. I think this is what we need. And worldwide, the clinicians, the frontline warriors, if they say that the safety framework is only 32% effective, then I think that's a very, very candid report for all of us. So one main question, there are some very specific questions, but one main comment comes from Ms. Nadira Chaturvedi. Madam represents Patient for Patient Safety Initiative. That's a new organization which has been recently launched, specifically address the patient angle, the patient perspective of this organization. And she very rightly has pointed out, clarity of domains and steps will be helpful to improving safety culture in our hospitals. So I think your study has also truly echoed that sentiment. One important question has been raised by Pritha about safe patient handling devices for patient dignity and prevent work-related injuries amongst caregivers. So she's asking, do you feel this should be a strong assessment point for quality check? So amongst all the parameters, would you agree to this? I mean, that we need to prevent work-related injuries amongst the caregivers also?
Yes, absolutely. So that's, I could only focus on a few components of our research. There are many more studies. I think we published more than 20 studies on this project alone, and there are many other studies that I've been involved in. Caregivers are often exposed to patient safety incidents, and even where patients are exposed, there might be the second victim. We are all familiar with these discussions. I couldn't present any data on this, but I absolutely underscore this as well. We have seen the whole world has suffered from COVID in the last 2 years. Healthcare professionals have done an amazing, tremendous work, often been exposed to a lot of risks. So if we forget our professionals' work in hospitals, then we're really starting in the wrong place.
Fantastic. No, I think that's very well said. Another very thematic question which Supriya Sarkar is asking is, how do you measure the teamwork climate? You categorize teamwork climate and safety climate, right? So she's asking, how do you measure it? What is the validated tool for that? And how to quantify climate and culture as a whole? I mean, these are how to transcribe them as tangibles and then find something meaningful out of them.
Yeah, so that's a very good question. The whole idea is that, as I explained, the cultures are lying deep. The climate is something that you can observe, but a climate, to observe a climate would be very costly. You would need to have such as an accreditation surveyor or a team of surveyors running through the whole hospital, observing and ticking boxes all the time about how was that communication now? Was the doctor polite to the nurse? Did the nurse share the news about something missed with the doctor? You can't observe all of that. So therefore, surveys are used. anonymous surveys in which the professionals are being asked questions. If something happened to you, for example, if you committed an error, would you tell your colleague about that? Would you document it? Is there a formal way to document it? Would your supervisor react on that? Would your supervisor have data on that? These are the kind of questions that the survey will collect. And then, of course, there are various tools that I've mentioned. We've used the patient safety questionnaire. And you know, I'm happy to share the slides. There are the references in the slides, and you can look up on those research. There are validated scales for psychometric analysis, and they have been considered quite robust. But the general approach is just imagine someone going through the organization, observing. What you can then translate to survey is what we measure with the safety climate.
No, the sharing of slides is what I think people are requesting for, and they'll really be a valuable addition to our resource map. Jaskaran Gambhir has hit the nail on the head. You know, he is very candidly pointing out that there's a gap in what is reported in checklist and what actually is actually. So how to sharpen the knife? Let's tone it down a little. So how to sharpen the knife, he says, for a more precise and accountable reporting. What's the way out?
I'm very familiar with that point. From various perspectives, of course, from a methodological perspective, there are some ways to actually adjust for underreporting. From the professional perspective, since I've worked some time also for the Royal College of Surgeons, I'm of course also aware of the whole discussions about time being taken to fill in checklists rather than dedicating the time to the patient. So I'm very well aware of that. I think the trick is to find a balance. We can't fly a plane without any checklist at all. No, it's not possible, because otherwise planes would be crashing all the time as they did 30, 40 years ago. But the pilots should also fly the plane. If they, during the flight, had to fill in another 20 checklists, maybe they wouldn't have time to look for the weather or other things. Applied to healthcare, it's the same. I think we need to have checklists that are very concise, that don't take much time away from the clinicians, that are developed collaboratively with the clinicians to ensure that the right pieces of information are being requested. And I also know from talking with a lot of surgeons that there are individuals that say, I don't like it. Yeah, because they're feeling that this is infringing on their autonomy, on their professional expertise. And I think my answer to that is no one is questioning the expertise, but working in a team, how else do you want to share the information, what has been done and what has not been done? It's about teamwork, whether it's a surgical theater or the care delivery on the ward. And so that's really important, to bring everyone up to speed. What has been done? Where do we stand? And for that, we need to have minimal checklists that are clear and concise.
Right. So checklist is the way to be. Actually, you can't wish them away, howsoever expert you are in your chosen field. I think you've answered the Sheikh's question also, because he mentioned that patient safety culture, is it a myth or a reality, and explain in the context. You've already mentioned that the form, time taken to fill the form, we can devote better in healthcare. But in India's scenario, maybe a little tweaked actually. The population, the resource challenge and everything. I mean, there are patients falling upon themselves to be seen. And the average consultation time, unlike Europe, drastically comes down to fraction of a hour, if not a minute. So that thing also is a reality, and that. And all there, the analogy between flying a plane and seeing a patient may not be a very apparent one. Usha Nambiar, madam, is requesting that measuring patient experience and their perception and confidence in patient safety activities in the hospital may also be a reflection of success of our efforts to improve patient safety. I agree with that. So, rephrasing your question, Jaskaran, is again, are we overburdening the frontliners with more reporting? I think this is just lethargy. I'm sorry. I mean, it's a rhetoric question. So, but quality is the way forward. I think you will totally agree, and you are a true ambassador, Dr. Oliver. one more comment from Nadira Madam is, culture is a derivative of many interventions to the end goal. Could you recommend 5 or 6 most important interventions or domains for starting a safety culture in a care facility? I think you've outlined the 7, rather 5 or 6, Madam. I think when you share the slides, the last slide, the summary, the wrap-up was very, very apt. And prior to that, the study reference also will be an eye-opener for all of us. So, ego problem. Yeah, Saik is continuing that ego problem among professionals also providing reducing patient safety. Would you agree, Dr. Oliver? Does ego figure in it? The bigger the clinician, the bigger the surgeon, bigger their ego, and why should we take time to fill up that checklist? I think that's in agreement that your data supports that.
Yeah, I have to say again, I'm initially trained as a medical sociologist, and you know, sociologists study the professions, in particular the medical professions, in detail. But I think I'm also, and I also said that I've worked very closely with surgical colleagues for many years. And I think we do need this data, but I also agree that not all the surgeons, why should they fill in all this data when they could use the time better? I think sometimes in the hospitals, we are only thinking very traditionally about data. If you look at any industry organization or high-tech organization, they don't leave the data collection to their best paid engineers. They employ staff to collect data. They have machines that collect data. They have routine electronic systems that collect data. Now, I've designed a national surgical audit in the UK, and we had multiple discussions. Do we need this? Sometimes it's about explaining what do we want to do with this data. If I was asked to fill in for every person I see 5 points on the checklist and I never get a feedback that I believe is useful for me, I wouldn't do it either. You know, we need to explain how we can use this data. And if it improves patient safety, I'm sure the clinicians will be the first to say we are embracing that. And I think there has been a huge gap in communicating the need for this data and the need for all this data collection.
I totally agree. I think it's very important, to close the loop, actually. Give a positive or a negative feedback of the data collected to the clinicians, and ultimately it must flow down. Yeah. I think this has been a very illuminating 1 hour. And thank you so much, Dr. Oliver. I think this is wonderful. And there are many people who are requesting to see that, to share your valuable PowerPoint. With gratitude, I pass over the mic to Dr. Lalu for the summation. And I think there are so many take-home messages for all of us that clinical safety, patient safety checklist, they are all here to stay despite resource challenged. Whatever we may say, we have to work together. In fact, just to compare, India has 28 states and 8 union territories, and each of them is a country of its own. And language also changes every 2 kilometers. So these are the challenges which we may face when we come across and devise a quality improvement prospective study of our own. But your sociology knowledge will come in very handy, and I'm sure that we'll lean on to you for guidance in framing our protocols. So thank you so much once again on behalf of CAHO, ISQua, and NABH partly. So over to you, Dr. Lalu Madam.
Thank you. Very interesting session. I thoroughly enjoyed, and I'm sure all participants would have been, greatly benefited by this session. Thank you, Dr. Atul, for moderating it so well and for taking up all the relevant questions. Thanks, Dr. Oliver, for that brilliant presentation. This is the certificate of appreciation to you, Dr. Oliver. We would certainly like to meet you in person and hand over, but considering all the restrictions at this point in time, so we thank you very much, participants, for your patience, and thank you, Dr. Oliver, for joining us, for taking your time, Professor Atul Mohan Kochhar, for joining us today, and on behalf of CAHO, the Governing Committee, President Dr. Vijay Agarwal, group of patrons, and all the Governing Committee members of CAHO, it's my pleasure as Secretary General of CAHO to thank you all